my name is Tim. I'm one of the second year paramedic students. Could I please confirm your name and date of birth?
Joshua Vitale, 1st of August 1994.
Thank you. Today I have been asked to perform a respiratory exam on you. This will firstly involve me assessing you from a distance and then moving in closer to assess you with a stethoscope. Is this okay with you?
Yes, it is.
The respiratory exam would be best performed with the patient at a 45-degree angle in an ambulance stretcher. For the purposes of this examination, the patient is seated at a 90-degree angle. At the moment.
No.
Could I please ask you to remove your shirt for me?
Okay.
By this point, without even touching the patient, I can assure that this patient is not a time-critical patient. That he has passed the primary survey. He obviously has a clear airway, he's breathing, he's alert and conscious, and has a pulse. If any abnormalities were found in the primary survey, I would first stop to correct these before moving on for the rest of the examination. I'm now going to perform a general inspection from a distance or from the end of the bed. Firstly, we look at the patient's position. He is sitting upright in a comfortable position. An acute patient could be expected to be found either in the tripod position, with their hands on their knees trying to increase the volume of air in their lungs, or maybe unconscious on the floor, such as a status 1 asthmatic patient. Looking at the bedside environment to see that if any treatment adjuncts are near the patient. We look for things such as home oxygen, nebulizers or inhalers. These could suggest a patient with previous existing respiratory conditions. Next, we assess to see if the patient is short of breath. This is assessed by firstly looking at the patient, seeing if they have pursed lips, secondly, by assessing the number of words per breath. As he has already said a few sentences to me, I can see that this patient has normal words per breath. Alternatively, we could get this patient to count to 10 for us and see how many words are involved in that sentence. As the patient's colour and perfusion, we look for signs such as cyanosis, blue lips, or a pale appearance. In a blue bloater, we could expect a barrel chest. This could be signs of chronic bronchitis, or a pink puffer such as emphysema. Next, we're going to assess the patient's hands. Could I please ask you to put your hands out for me? Here, we're firstly inspecting to see if there is peripheral cyanosis. We can clearly see that his hands are well perfused, of good colour. Next, I'm going to check the capillary refill. This is done by pushing on the fingertip. A capillary refill under 2 seconds is indicative of normal perfusion or blood flow. Next, I'm going to take the patient's pulse. Whilst doing this, I can also take the patient's respiratory rate. A radial pulse would be best taken for a conscious patient, and an unconscious or acute patient it would be best to take the carotid pulse up here. A respiratory rate of between 12 and 20 is considered normal. Anything less or above this is considered time critical or acute. Cool. Could I now ask you to put your hands out for me, like this? Now we're looking to see if there's a tremor. A tremor could indicate beta-2 agonist use, such as salbutamol. Next, I'm going to inspect the patient's chest. So firstly, we're looking for central perfusion. So we can check the capillary refill here by pushing and releasing. Under 2 seconds is also considered normal. Next, we're looking for obvious scars. There is no obvious scars apparent on this patient's chest. Things that could indicate previous surgeries. I'm now going to palpate the patient's chest. Firstly, we look for equal chest expansion. Could you please take a deep breath for me? Here we're looking for symmetrical movement of the thumbs. Decreased air entry on one side could be suggestive of a collapsed lung. Next, I'm going to feel the patient's chest for crepitus, lumps or deformity. Is there any pain when I'm doing this? I will assess the patient's head and neck. Firstly, we're going to inspect the lymph nodes to see if they are swollen. Swollen lymph nodes indicative of an infection. Next, we will assess the level of the trachea. You should be able to feel the rings and should also be able to feel that it lies midline. A tracheal deviation could be indicative of a tension pneumothorax or a collapsed lung. In a tension pneumothorax, the trachea would be expected to move to the opposite side, and in a collapsed lung, the trachea would be moving to the side that is collapsed. It's the venous jugular pressure, so we get the patient to tilt their head to one side, and we're looking to see along the borderline of the sternocleidomastoid muscles to see if there is an obvious visible jugular venous pressure. Next, I'm going to percuss the patient's chest. A dull sound would be indicative of fluid underneath the space. A hyperresonant sound could be indicative of air. A normoresonant sound is what we expect to hear. This involves assessing the quality and volume of the breaths. Can I please ask you to take some deep breaths for me?
Okay.
It is expected that we'll hear clear bilateral air entry. Crackles may be suggestive of fluid in the lungs. A wheeze may be suggestive of things such as asthma, COPD, or smoke inhalation, where the bronchioles have become narrowed. I'm going to assess the patient's vocal resonance. An increased vibration could be suggestive of fluid in the lungs. Can I please ask you to say 99 every time I place my stethoscope on your chest?
99. 99. 99. 99. 99. 99. 99. 99.
Now I'm going to assess the patient's back. Could I please ask you to fold your arms and lean forward for me? Firstly, we're doing a general inspection on the back. We look for any obvious scarring, crepitus, lumps, deformity. So we're going to palpate the patient's back. Next, we'll look for chest expansion. Deep breath. There's equal movement of the thumbs. This is good expansion bilaterally. Next, I'm just going to auscultate the chest. Some deep breaths for me. Can I get you to say 99 for me?
99. 99. 99. 99.
Thank you. Now I'm going to percuss the patient's back. Now I've asked the patient to lean back for me. This completes my respiratory exam.
In summary, today's assessment was based on a young 20-year-old male called Josh, who appeared comfortable at rest and not short of breath. The patient was of good colour and was well perfused. On palpation, there was equal rise and fall of the chest. There was no crepitus, lumps or deformities. On auscultation, there was a clear bilateral air entry with good tidal volume. On percussion, all landmarks were normoresonant. Josh was classified as a status 4 patient. Patient status would be based on the level of respiratory compromise. In comparison to this, a patient that is status 1, such as one with immediately life-threatening asthma, would be extremely short of breath. They would not be moving much air and are usually unable to speak more than 2 words per breath. They usually have marked indrawing of the chest unless exhausted and may not be moving enough air to produce a wheeze. There may also be a falling level of consciousness. Patients that are status 2 have severe asthma. They are short of breath but are moving air and usually able to speak more than 2 words per breath. They usually have chest or neck indrawing. Patients status 3 or 4 have moderate or mild asthma. They are short of breath but moving air, able to speak full sentences. They do not have significant chest or neck indrawing. Any abnormalities found in a respiratory exam would require further investigation within a hospital environment.
Hi there, my name is Tim. I'm one of the second year paramedic students. Could I please confirm your name and date of birth for me?
Joshua Vitale, 1st of August 1994.
Thank you. Today I've been asked to perform a cardiovascular exam on you. This will firstly involve me inspecting from a distance and then moving in closer to have a look at your heart. Is this okay with you?
Yes.
I'm first going to ask, are you in any pain?
No.
Okay. Ideally this exam would be best performed with the patient at a 45-degree angle. For the purposes of this assessment, the patient is at a 90-degree angle. Could I please ask you to undress from the waist up for me? Start with a general inspection from the end of the bed. Here we're looking for things such as a home oxygen bottle that may indicate previous existing cardiovascular disorders. Next we check to see if the patient is comfortable at rest. Have they been experiencing any shortness of breath today, and what position are they in? At the moment the patient looks to be quite comfortable and not experiencing any shortness of breath. Next we looked at the patient's colour and perfusion. Do they have any flushed skin or anything that's immediately noticeable? From this point we can determine the sick versus not sick patient. Here we have already completed the primary survey. We've already seen that the patient clearly has an airway, he is breathing, he has a good blood pressure because he's sitting upright. The patient has been able to verbalise to me so that I can confirm that this patient is not acute or time critical. Next we're going to inspect the patient's abdomen. First we're looking for scarring on the chest, things that could be indicative of previous cardiovascular surgeries. A cabbage may have a scar from here to here on the patient's chest. We're looking for things such as a pulsating mass, which could be indicative of a dissecting AAA. Next we're going to look at the patient's colour. Are they cyanosed? How hypoxic are they? When you are looking for things such as ischemic coronary artery disease, the patient may present with pale skin. Next we're going to check the patient's temperature. So just having a quick feel. Cool peripheries may suggest low cardiac output. Next we're going to look if the patient is sweaty or clammy. This could be associated with things such as acute MI. And lastly, we're going to inspect the patient's legs. In heart failure, we look for things such as peripheral edema, so just swelling in the legs. Next, we're going to inspect the patient's hands. This firstly involves taking a radial pulse, so feeling for the rate and rhythm and recording it. Then we're going to look at the capillary refill, so anything that's under 2 seconds is considered normal. Anything above 2 seconds could be considered a cause of hypovolemia. Next, we're going to look at the patient's brachial pulse. Once we've identified this brachial pulse, we can then take a blood pressure. It is at this point of the assessment where I put the blood pressure cuff on and listen for a blood pressure with the stethoscope. Next, I'm going to inspect the patient's head and neck. This firstly involves looking at the carotid pulse. We're looking for brisk upstrokes. We're then going to look at the patient's JVD. So can I please ask you to tilt your head to one side? Here we're looking along the borderline of the sternocleidomastoid muscles, and we're looking for how far up the venous pressure is being reported. Things that would increase the JVD could be things such as fluid overload, cardiac tamponade, or right-sided heart failure. We're then going to check to see if the patient has any pallor anemia. Can I get you to pull down on your eyelid for me? We're then going to look for any central cyanosis around the lips. So can I get you to poke your tongue out for me and then raise it? Next, I'm going to inspect the chest more closely. Firstly, we're looking for things such as crepitus, lumps, or deformities. This can involve a quick palpation of the chest. Any traumas to the chest could have implications on the heart or the cardiac outflow. Is there any pain when I'm pushing there? Next, I'm going to feel for the apex beat. This is along the fifth intercostal space in the mid-clavicular line. Lastly, we're going to auscultate the patient's chest. This involves listening to the 4 heart valves. Lastly, I'm going to auscultate the back of the chest. Could I please ask you to sit forward for me? Could you please take a deep breath? And once more. Here we're auscultating the lung bases. We might expect to find crackles suggestive of cardiogenic pulmonary edema. We're also going to palpate the sacral area of the back. Here we're palpating for sacral edema, which could be suggestive of heart failure. That is the examination finished. You're more than welcome to get changed now. Hi there, my name's Tim. I'm one of the second year paramedic students. Could I please confirm your name and date of birth, please?
Joshua Vitale, 1st of August 1994.
Thank you. Today I've been asked to perform a neurological exam on you. This will firstly involve me inspecting from a distance and then performing a few basic tests on you. Is this okay with you?
Absolutely.
I'm firstly going to ask if you're in any pain.
No.
Okay. We're now going to do a general inspection. First, we'll be looking around the patient's bed. Are there any mobility aids? These could be things such as a wheelchair or a walking stick. We're then going to look at the patient's posture. A resting tremor could be indicative of Parkinson's disease. We're then going to look at the patient's appearance. If there are any signs of neglect, such as alcoholism, an acquired cause of cerebellar ataxia. I'm now going to observe the patient's normal gait. Firstly, we're looking for stance and then stability. Could you please take a few steps for me? A broad stance is normally indicative of cerebellar disease. Also, instability suggestive of like a drunk person staggering. And next I'm going to ask you to do some heel-to-toe walking for me. This is also indicative of cerebral ataxia if they can't perform this motion. Cool, thank you. I'm next going to ask the patient to perform the Romberg's test. So can you please stand with your feet together and your hands by your side and close your eyes. This test is testing proprioception, so it's looking to see if there are any swaying movements in the patient while you're standing here. Next, I'm going to assess the patient's head. Firstly, I'll ask him to say a few words. Can you please say baby hippopotamus?
Baby hippopotamus.
British Constitution.
British Constitution.
Thank you. Slurred speech could be indicative of a stroke or a lesion. Next, I'm going to test the nystagmus of the patient. Can you please follow my finger with your eyes? We're looking for pronated drift. So can you please put your arms out like this for me, close your eyes, and now we're going to wait 20 seconds. We're looking for pronation of the palms, which could be suggestive of a lesion. Next, I'm going to test the patient's rebound phenomenon. I'm going to ask the patient to put his arms out like this, to close his eyes. I'm going to push down on the arms and release, and to see which position they bounce back up to. If one of them raises higher than the other, it could be indicative of something wrong in the brain. Next, we're going to test the patient's tone in their elbow and arms. So I'm going to grip the patient's arm like this. I'm going to ask him to let it go floppy for me, and I'm going to take full control of the arm. I'm going to see if there's any resistance to movement when I'm moving the arm either way. And then going to repeat it on the other arm. To assess the patient's reflexes, we usually use a medical hammer to test the supinator, the triceps and the biceps, which would involve tapping on the nerves and looking for a rigid movement of the arm. To test the patient's coordination, can I please get you to touch your nose and touch my finger? Now I'm going to assess the stylokinesia. Could I get you to perform this movement for me? Cool. And then with the other hand. An inability to do this could suggest a cerebral ataxia. Next, I'm going to perform an assessment of the legs. Could I please ask you to keep your legs floppy throughout the course of this assessment? First, I'm going to perform a leg roll. This is when we move the upper part of the leg and watch the foot flop independently of the leg. Next, I'm going to perform a brisk knee motion to lift the leg up, and to lift the knee up, the heel should remain intact. To assess the patient's reflexes in their legs, I would tap with a hammer here to see the knee jerk. I would then tap here to see the ankle jerk. We are then going to test the patient's coordination. Could I please ask you to use this foot to run down this shin and on the other side? Thank you. This completes the neurological assessment.